Thanks, Corey, and good afternoon to everyone. And I should introduce this lecture with the last answer to one of the questions. Immunotherapy works for everyone. Silly. Okay. I think my slides are, for some reason, not showing up as they should. Okay, let's go back here. Something is missing. Okay, I'm going to go ahead and describe my slides, but I think I'm missing some of the data here. As this audience is aware, we have received approvals for frontline immunotherapy already since last year. I can see it appearing now. And I think the major surprise in the field of immunotherapy has been the disparate results we saw between the KEYNOTE 024 and CheckMate 026 because the studies are read out at the same time. There were differences between the two studies in terms of inclusion criteria as it pertains to the biomarker selection of the patients. But beyond that, the differences were very, very subtle. However, pembrolizumab is now a standard of care agent for patients with expression of 50% or more of PD-L1 in their tumor based on KEYNOTE 24, and CheckMate 026 was not able to demonstrate that Nivolumab as a single agent is superior to combination chemotherapy for our patients. And these are the curves that are very well publicized and published, so I'm not going to ponder on these results for too long. This is extended, updated survival for KEYNOTE 24, demonstrating that the benefit is long-lasting, and there is a tail of this curve, which we're going to be following, hopefully seeing some patients surviving to our 5-year mark and being able to demonstrate that we have maybe reached at least long-term remission, a term that we were not able to use in the past for lung cancer. The survival benefit was evident in all subsets of patients that were treated with pembrolizumab with 50% expression of PD-L1 or more. But you can see that some groups of patients appear to have better outcomes. For example, East Asian patients appear to be benefiting for whatever the reason. We see that the current and former smokers do better than never smokers, but the benefit is across the board. Why did we see these differences? It's still being debated, and it's not entirely clear, but I think the people that participated in these studies and the leaders of these studies wanted to look beyond PD-L1 expression to try and understand why we saw these differences. And this analysis was presented last year at AACR by Solange Peters, but included a component, not all of the components that you see in the slide, but the major component was tumor mutation burden analysis to have another look at the results of the CheckMate study. I want to spend a minute on this slide because it's a very nice slide putting together the potential biomarkers that we could attach to the exploration of who benefits from these therapies in frontline, not only non-small cell lung cancer, but also other tumors. And this includes the mutational landscape of the tumor, the potential inflamed tumor microenvironment as it is expressed in signatures mostly, and PD-L1 expression, factors such as tumor suppressive cells in the microenvironment, Tregs and MTCs being the most common ones, and some of the molecules that correspond with immune suppression in the microenvironment, IDO and LAG3, and finally things such as the microbiome and germline genetics. And this is another Venn diagram put together by Kurt Schalper to try and explain how complex the study of all these factors can be, but likely important to do, at least in exploratory fashion, in our trials. So tumor mutation burden has already been shown to be a predictive marker in melanoma, and this seminal paper by Nair Rizvi demonstrated that it determines sensitivity to PD-1 blockade using second-line therapy cohort. This is from the paper demonstrating that responses, it's not very well visible, it's in the second row of this table underneath, seem to be corresponding with increased mutational burden. The analysis demonstrated that this is true for the subset of patients that was analyzed for tumor mutation burden in the CheckMate study, clearly demonstrating that patients with high tumor mutation burden seem to benefit from therapy compared to chemotherapy, and that was not true for low or medium tumor mutation burden. When the two biomarkers were put together, there was the interesting observation that the group of patients that had both biomarkers seemed to benefit the most on Nivolumab. So you can see the numbers are small, but the response rate is very high, 75%, the blue column. While patients that have low tumor mutation burden seem to benefit from chemotherapy most, and the high tumor mutation burden appears to be the predominant factor for response to Nivolumab. This is shown again here in the curve, and I think it was shown before in the prior talk. Overall survival, though, did not correspond to the progression-free survival results we saw. I didn't pay attention whether you presented this, Josh, or not. This is felt to be because of the high crossover rate to second-line immunotherapy for patients that did not receive it in the front line. Here is again another clinical factor in correlation with tumor mutation burden. It appears that current and former smokers are the ones that appear to have the highest tumor mutation burden, as one would expect. And this diagram tries to put the whole picture together. So we know that when we look at our tumors and select patients for therapy, we encounter patients with high PD-L1 expression and high tumor mutation burden, and this is the group that seems to be performing the best. In these cases, PD-L1 expression may be a surrogate marker for high tumor mutation burden-induced inflammation. Then we see a group of patients that has low tumor mutation burden and high PD-L1, and in this case, inflammation may result from activation of alternative pathways. And finally, we see what we would call a tumor-excluded T cells with high tumor mutation burden. In this case, the tumor cannot demonstrate inflammation because of lack of PD-L1 upregulation. So we have all these potential groups with benefit demonstrated in the high PD-L1 group. We need to find ways to activate or transform cold tumors to hot tumors for the remainder of the groups. This is the analysis demonstrating again that Nivolumab responsiveness to therapy is driven by high tumor mutation burden, while for the chemotherapy-treated patients, high tumor mutation burden appears to be detrimental, as you heard in prior talks. This is data from melanoma demonstrated again in head and neck cancer and a number of other tumors, showing that an interferon inflammatory signature appears to predict for clinical response to PD-1 blockade. What do we know about combining chemotherapy and immunotherapy? And I think my comment at the introduction was immunotherapy works for everyone. This is a study that has been associated with a lot of criticism in the academic community, and we're still waiting for confirmatory data. And to some degree, I think the criticism stems from the fact that it depersonalizes our approach. So immunotherapy in combination with chemotherapy based on the study appears to be the answer for all of our patients. And I'll go over the results. This was a randomized study, expansion of a cohort of a small phase 1 study investigating the idea of inducing immunogenic cell death with combination of chemotherapy and immunotherapy, comparing standard chemotherapy with the addition of pembrolizumab. The primary endpoint was response rate, and it was clearly and statistically significantly better with the combination. And progression-free survival was also significantly better. Overall survival at the initial presentation of this data by Dr. Langer was not statistically significant different between the two groups, but with more mature follow-up, we see a separation of the curves favoring the pembrolizumab and chemotherapy combination. This comes, of course, with all the caveats of small size and not predefined. This is not the primary endpoint for the study. However, an interesting signal that we're waiting for confirmation. There are a couple of other studies that are trying to capitalize on this PD-L1 positive mostly signal. This is a combination of an IDO inhibitor, epacadostat, with pembrolizumab that was presented at ASCO. And in a small cohort of patients, 35 patients with lung cancer, we see that the response rate to the combination was 40%, with 2 CRs remarkably and 12 partial responses. An initial signal that will be leading to phase 3 studies. Another interesting combination in the first-line setting is combination of anti-angiogenics with immunotherapy based on rationale that is biologically plausible. VEGF induces suppression of T-cell responses, promotes and expands inhibitory immune cell subsets, and induces immune cell trafficking across tumor endothelia. The study that was recently presented is a combination of pembrolizumab and ramucirumab, but this combination is also being studied with atezolizumab and bevacizumab. There are also TKI combinations that are being explored, not in lung cancer. So this is the cohort of patients as part of this large basket study with combination of ramucirumab and pembrolizumab. And these are the initial results, also encouraging results, with a response rate in this, again, immunotherapy naive setting that is encouraging. A number of studies are exploring similar ideas. So they're listed here in tables because they haven't read out yet. The studies that are designed with combination, a backbone of atezolizumab and chemotherapy, range from combinations of chemo, immunotherapy plus anti-angiogenic, IMpower 150, to simple doublet combinations of chemotherapy with immunotherapy. And in all of these, except one, PD-L1 is not required for entry. IMpower 110 is the study that compares single-agent atezolizumab with platinum doublet in an enriched population using immunohistochemistry test either in tumor cells or inflammatory cells that are positive. This is the primary endpoint for these clinical trials, PFS, and these are the primary endpoints for 110 and 111. As I already mentioned, KEYNOTE 189, which is at the bottom of the list, is the confirmatory trial that explores or tries to confirm the data that we already saw with combination of pembrolizumab and chemotherapy with a primary endpoint of progression-free survival. There are also explorations of use of pembrolizumab as monotherapy for patients with PD-L1 expression of 1% and above against the platinum doublet, and also in squamous cancer with carboplatin paclitaxel or nab-paclitaxel. What about combinations of two immunotherapy agents? This slide has been shown at many meetings, includes the rationale for combination of anti-CTLA-4 and PD-1 pathways. And this combination has been shown beneficial in melanoma, non-small cell lung cancer, small cell lung cancer, as you heard from Dr. Rudin a little while ago, and mesothelioma. The melanoma trials are definitive. The other studies are still early. This is the mesothelioma study. This is CheckMate 012, which explored the use of Nivolumab and Ipilimumab in a meticulous fashion, escalating the dose of both agents and the interval for therapy with Ipilimumab, with the conclusion that dose intensity for Nivolumab was most important as part of this regimen, and de-emphasizing or de-escalating Ipilimumab was not associated with deleterious effects for response and actually beneficial in terms of side effects. Still, the side effect profile of this combination was originally scary. We now have used it a lot with many of our patients, and we know that the degree of any grade toxicity is increased compared to Nivolumab alone. Grade 3 and 4 toxicity is also higher. Dr. Bazanova will discuss a little bit the management of these side effects, I think, in a bit, but this is a visual of what to expect with these agents. So the toxicity is significantly increased compared to Nivolumab alone, and I think there are organ systems that are more important to us, such as renal, pulmonary, and hepatic toxicity, and there the differences are not so high. Where the differences really are visible are for skin toxicity and gastrointestinal toxicity. The results, though, were highly encouraging from this original first-line non-small cell lung cancer study with the combinations that include Ipilimumab at 1 milligrams per kilogram every 12 weeks and every 6 weeks, showing the best results. PD-L1 expression appears to trend in the same direction as single-agent Nivolumab. So the responses are highest, as high as 92% in patients that have PD-L1 expression of 50% or above. Smoking status is also consistent with all the other studies that we have seen so far. Current and former smokers appear to be benefiting from this combination therapy most. We haven't seen tumor mutation burden analysis yet for these studies. EGFR mutation status, again, this is a small number of patients, appears to be, in this case, non-affecting the response of Ipilimumab and Nivolumab in combination. But again, we need to look at the numbers, which are really, really small in this trial. The same idea is being explored with the MYSTIC trial, and as you know, the primary endpoint for this trial was PFS and reported as negative. The study was revised to include OS as a co-primary endpoint, and we're still awaiting the results of this study. This is the press release that showed that Durvalumab and Tremelimumab in combination did not meet the primary endpoint of the clinical trial. Not a big surprise to many in the community, since in the majority of cases, we don't expect to see progression-free survival being superior in this population. CheckMate 227 is the definitive study comparing the combination of Ipilimumab, Nivolumab with chemotherapy and Nivolumab monotherapy. This study is also trying to explore, based on PD-L1 status for negative patients, the combination of chemotherapy with Nivolumab against the combination of Ipi and Nivolumab and chemotherapy. So this is the expected results from these studies. I'm sorry, these are the primary endpoints from these studies. Overall survival and progression-free survival for CheckMate 227 and CheckMate 568, which is exploring doublet plus platinum chemotherapy against platinum doublet, has a primary endpoint of response rate and overall survival. I wanted to put a plug in for the S1400 immunotherapy naive cohort of squamous patients, because this is the only trial that I think is exploring the combination of Ipilimumab and Nivolumab against Nivolumab in squamous patients as part of this trial. And also describe the study that is being run by the Canadians with combination of Durvalumab and Tremelimumab in combination with chemotherapy versus platinum-based chemotherapy. So this is the collision of the giants, or whatever is going to happen in the next 6 months is really going to confuse all of us. So this is what the landscape of reading out of clinical trials is going to look between, let's say, December of 2017 and 2019. A lot of these trials are going to read out, and we're going to have to meet again with Corey here to interpret them. I'm going to skip these slides because I'm getting to the end of it, and I think I'm over time. So in conclusion, just to make it very simple, for first-line therapy, what we know is that patients that have high expression of PD-L1, PD-L1 being the criticized biomarker it is, pembrolizumab is the standard of care for these patients. For patients with less than 50%, platinum doublet plus minus pembrolizumab, awaiting the confirmatory trial results, I think is an option for our patients. I use it in my practice, but I try to follow the paradigm of the clinical trial in terms of selecting the patients that are best performance status for this clinical approach, and I have not generalized it in my practice. The IMpower trials, the CheckMate 227, KEYNOTE 189, and MYSTIC are the trials that are going to change the landscape in the next year. Novel combinations, some of which I presented already, to enhance responses in PD-L1 positive, TMB high patients are being explored. But I think what is really, really needed in this setting is addressing the patients that are intrinsically resistant to this therapy. And with this, I'm going to stop.